Presenter for today, Tony Klein. Tony has a Master's of Public Administration degree with a concentration in healthcare management and holds numerous credentials in substance abuse counseling and training. With over 30 years of administrative, clinical, and training experience, he is known for his work as an advocate for addressing tobacco dependence and addiction services and the development of a tobacco intervention model that utilizes evidence-based practice guidelines anchored in 12-step teachings and therapeutic community principles. Mr. Klein served as a member of New York State Partnership for the Treatment and Prevention of Tobacco Dependence, the work group that consulted New York State Office of Alcoholism and Substance Abuse Services on drafting Regulation 856 requiring 1,500 New York State certified substance abuse providers to develop tobacco-free services. Mr. Klein has coordinated the establishment of a continuum of tobacco interventions linking inpatient and outpatient treatment and has served as principal investigator for a 3-year study to evaluate a systems approach for tobacco-free residential services. He provides consultation, training, and technical assistance to community providers, municipalities, and state agencies. In addition, Mr. Klein serves as manager of outpatient services, Rochester Regional Health, Unity Chemical Dependency in Brighton, New York. We at the American Lung Association have brought Mr. Klein to statewide conferences and have really appreciated his insight about the relationship between tobacco and other addictions. We're happy to have you join us today. Thank you, Tony.
Thank you, Janelle, and good morning, everyone. This is, I believe, the 4th webinar in the series. Let's look at the list here. So the last time we had a webinar was back in April, where we spoke of tobacco recovery. Today we're going to expand on discussing practical counseling skills to help our clients to establish and maintain tobacco. And we're going to apply that information to clients with co-occurring substance use disorders and mental illness, and also share some information on persons living with HIV. Our learning objectives for today will include identifying the prevalence and impact of tobacco use specific to these clinical populations. We want to adapt some of the tobacco intervention strategy that we spoke of to appropriately address the comorbidity factors, and then talk about some of the coping techniques of how we can utilize those within our behavioral interventions for addressing this population. Now, you may recall seeing this slide from a previous webinar. We identified that individuals with mental illness and addictions continue to smoke at a significantly higher rate than the general population. We're going to find this also to be true among those who are HIV infected. While it's believed that approximately 20% or so of the U.S. population has some type of mental illness and or substance use disorder, this group accounts for 40% of the U.S. cigarette market. Pretty scary stuff. And while there are multiple factors for a reduced lifespan among individuals with co-occurring disorder, tobacco use is the primary factor. Cigarette-related respiratory and cardiovascular diseases are the leading causes of premature death within this group. In addition, there's been some studies that suggest tobacco dependence is a risk factor for suicidal thinking and attempts for people with psychotic disorders, bipolar illness, or schizophrenia. Now, it's believed that we find such a high prevalence among those with co-occurring disorder due to attempts to self-medicate some of the affective and cognitive deficits associated with mental illness. In late January, I think it was, of this year, a study was released involving the University of Colorado at Boulder that provided evidence that nicotine normalizes brain activity deficits that are key to schizophrenia, attention deficit disorder, and bipolar disorder. Zodonis and Williams suggested that there are 3 broad categories to explain tobacco use among this clinical population: the biologic and pharmacologic aspects, the psychological and behavioral factors, and then they spoke of systemic in some of the treatment factors that we need to recognize. Now, While certain aspects of smoking behavior may be partially genetically driven, findings are fairly inconsistent and generally weak with regard to some of the biological aspects to this. Conditioning effects are much more significant. The cigarette, again, the perfect nicotine delivery device, is hijacking the brain into addiction, I like to say. If one takes 10 puffs on a cigarette and smokes a pack, that's 20 times 10, 200 doses of nicotine daily. So again, it's very highly reinforcing. The social interaction factors for smoking is huge. Persons with co-occurring disorder often have limited socialization skills. One of the projects that I worked on years ago was a 3-year study looking in residential care. And a common aspect of the ways that folks would connect socially, they would report was a substance. So it's either you're sharing the cigarette, you're sharing the joint, you're connecting on that level. And a lesson learned from the study that we did was that if we want to have effective tobacco interventions in residential care, we need to make sure that we provide living skills, more counseling and therapy of how to socialize with one another. So it was an eye-opener for us to recognize that. As we're examining the nature of tobacco among those with co-occurring substance use and psychotic disorder, it's important to acknowledge the rate and the intensity, how they draw on the cigarette in order to self-medicate. So we find a very deeply drawn, the intensity of drawing the smoke into the lung, smoking the cigarette right down to the filter. There's more puffs. There's shorter period of time in between the hand-to-mouth motion and the inter-puff interval, like we like to say. So the actual, the intensity, again, of how we see this just through casual observation, how the tobacco use behavior tends to be different than in the general population. Smoke more heavily and efficiently, again, is the key. This is important to explore when we're prescribing NRT. So we need to make sure that we have an adequate understanding of proper replacement dosing. As opposed to asking how many cigarettes a day that you smoke, we need to kind of dig in a little deeper to really understand the pattern of how the tobacco use is definitely the actual inhalation aspect of it. Among those with schizophrenia, the research will also show that there's an increased psychiatric symptoms related, again, to increased hospitalizations and higher dose of psychiatric medications. Now, people with co-occurring disorder are more likely to have stressful living conditions. And poverty is something we have to mention because it, brings with it limited opportunity for education, employment, lack of access to health insurance, often a need to live in a higher crime area. So the expense of buying cigarettes can amount to a very sizable portion of one's monthly budget. We often see more agitation among our clients toward the end of the month where due to running out of funds to buy cigarettes, they're forced to cut back and are starting to experience some nicotine withdrawal. The financial implications are something to talk about as we're providing counseling with our clients. Another very important point to make is that tobacco use has been found to contribute to elevated symptoms of anxiety, which reflects feelings of withdrawal. In counseling, I emphasize how we need to differentiate the feelings that are induced by tobacco withdrawal and those that are due to a generalized anxiety disorder. As I mentioned earlier, researchers have identified increased suicidal ideology among daily tobacco users with co-occurring disorder, most significant among those with psychotic disorders, and interestingly, the research also pointed to adolescent females. We know that tobacco smoke can interact with some psychiatric meds. It's not the nicotine, I understand, that causes that, but the polycyclic hydrocarbons that impact drug metabolism. but often we'll find a need for higher dose medications among tobacco users, and then that leads to other issues of side effects from the medications. There's a common misconception that persons with mental illness are not interested in quitting smoking. This data is looking at the stage readiness measurement of looking at contemplation, which would be intend to quit in the next 6 months, as well as preparation, intend to quit in the next 30 days. We see no difference between psychiatric illness and motivation measured by stage readiness. So this is very reflective, again, of the general population. The folks that we work with in our programs are highly motivated to stop their tobacco use. They just quite basically don't know how to do it. So we need to develop programming to help them with that. There's some key points here about how tobacco use impacts treatment. And again, this is looking at medication with regard to Ativan, but the 3 categories here in the dark blue would be the non-smoker. The gray bar reflects a smoker who is using a nicotine replacement therapy, and then the smoker who is the purple bar. And you can see heavier and more medication use among the smokers. More need for agitation, placed in seclusion, and the big takeaway from this particular study was we also see greater AMA discharge among smokers than non-smokers. So we think a lot of the anxiety, a lot of the agitation, a lot of the acting out behavior is actually reflective of tobacco use and the withdrawal effect. There was a 3-year study comparing symptoms of the disorders that are listed here. You can see that looking at year 1 and then comparing it with year 3, major depression, panic attacks, social anxiety disorder, and the rest that are listed here. Those who had stopped smoking, which would be the gray bar, you can see a reduction in the symptoms of all of these disorders, with the exception of panic attack. In year 3, we saw increased panic attacks, but in all the other areas, we found that by stopping tobacco use, there was a benefit there in terms of reduction in the symptoms related to these disorders. So tobacco abstinence, it seems to improve recovery from mental illness as well as substance use disorders, which are also listed here. Now, these are the tobacco interventions that we spoke of before. Once again, readiness is determined by how important this is to you, and then how confident are you able to do this. So we need to explore both the cognitive and behavioral change process. Tobacco awareness is learning how to engage, have that conversation to explore the importance, and then tobacco recovery speaks to the behavioral change and how we need to offer support and instruction for learning coping skills and proper use of pharmacotherapy. We want to match the intervention to the stage readiness. So the key method in counseling would be motivational interviewing when we're dealing with folks who are in a pre-contemplative or contemplative state. And then one is saying, yes, I want to do this. I really want to stop my cigarette smoking. It's more of a cognitive behavioral therapy where we want to be more prescriptive in terms of how we provide instruction around coping skills and behavioral modification techniques. Now, this is a stage-wise treatment as defined by SAMHSA, and I just wanted to show this to you to identify where the tobacco awareness or recovery interventions would be most appropriate. So in the engagement, persuasion, active treatment, and then the relapse prevention components of the treatment, you can see where this would kind of fit into the picture. Motivational interviewing, again, is where we begin the process. As we get into active treatment, relapse prevention, it's more of the CBT approach. This is components of the CBT program developed by Jennifer Gottlieb at Massachusetts General Hospital. And looking at the components that she has listed here, I love this program. It's very comprehensive. She had great success with this. Learning and coping with any triggers after you understand the tobacco use behavior. So really, when do you smoke? Are there periods of the day where you find that your tobacco use is more important than other times of the day? What are the reasons for the cigarette? Is it exploring that in depth with someone? Is it pepping you up? Is it calming you down? Is it helping you escape from your thoughts? Is it what's going on that the cigarette is something that's in the picture at any given time? Are things to really thoroughly explore with folks. The learning about medication, there's a lot of mythology around NRT where people don't fully understand how or why it works. So to provide good education around that, we have found to be very helpful as well. Coping with craving and withdrawal, we spoke a lot about this in the last webinar. Assertiveness training, again, part of the socialization or refusal skills. Setting goals and self-reward, and then relapse prevention. So again, returning to use, if that happens, what do we learn from the episode of use so that we can prevent it from reoccurring? So a lot of this is all of the various components that are very helpful as we're working with folks. Let me give you an example of this more in depth with someone that I had worked with. Her name was Mary, and I met Mary in a continuing day treatment program. I was asked to attend and meet with the community and provide a tobacco awareness session. Mary was someone who was in this program for many years. She just needed that support and level of care. She was a lady who was in her late 50s, although she really looked a whole lot older. She probably, looked 10 or 15 years older than she really was. And that was because she was very ill. Besides having schizophrenia and bipolar disorder, there was a lot of medical comorbidity. She had bronchitis, emphysema, cardiovascular disease, diabetes. She also had a fairly significant history of alcoholism and using cocaine, and was a very heavy tobacco user, something like 3 packs a day. Well, due to everybody loved Mary, everybody knew Mary. Like I said, she was in the program for a long time. In this program, there was a bench in the courtyard outside of the facility where, in between activity, group activity, and different things that they were doing in the programming, folks would go outside and obviously they would sit there and smoke. And Mary, this was her favorite spot, and so you would see her literally chain smoking all the time that she was out there. Well, every once in a while, over the years, I learned later, because of her illness and heavy tobacco use, someone would try to intervene, and they would attempt some type of a stop smoking program with her, but it really never amounted to anything. It never made an impact. And so anyway, long story short, I'm sitting next to Mary at this, I was invited in for lunch, and then we had our session afterwards. Got to know her a little bit. And after we had our discussion around tobacco awareness, which was basically why do you smoke, and what do you like about it, what does it do for you, kind of a cost-benefit analysis of a decisional balancing kind of an exercise is what I did with the group. Mary asked if she could meet with me to talk about this more, and I did. I decided that was this, again, the tobacco awareness type of intervention. So I said I could stop by the facility once a week or so if she were interested, and we could discuss her tobacco use more in depth. And it took 3 sessions. The third session of maybe 45 minutes to an hour in each session. We established a therapeutic alliance where she was now trusting me a little bit more. But that's when the message, that golden nugget of a moment came out, where She turned to me and said, can I really explain to you why it is that I smoke cigarettes? And I said, yeah, I'd be interested in hearing that. And now this was the mental illness talking, of course, but what she said to me was, there is a poisonous snake that lives inside of me, and it wants to eat my intestines. And the only thing that'll stop the snake from biting would be if I put cigarette smoke into my body. Now, think about that for a minute, because what was she explaining to me? It was her interpretation of cigarette craving. When she would experience the feelings of withdrawal and craving, she was relating that and interpreting it as a snake that was biting her. So I had to roll with that. I said, would you like to quiet that snake down? How can we work to make that go away? And that's kind of where we went with it. I consulted with her prescriber, and we used a higher dose combination nicotine replacement therapy. I taught her some grounding and mindfulness techniques, how to distract from the craving, the snake. And we made some significant changes to her behavioral patterns and environment, where actually rearranging furniture where she lived, and you don't go out to that bench. We had to find a different thing for her to do in between group sessions, and you're just teaching her some deep breathing and other types of grounding exercises. Long story short, it was very successful, and she was very pleased, and so was the staff. But the reason I'm mentioning this is the slow and the respectful approach of tobacco awareness before we start pursuing recovery, before we start pursuing behavioral change. We could have from day one said, well, this is how you use a patch, and establish a quit date and go for it. But I didn't do that. And I think with this population, we have to be respectful, where you have to really explore more motivation, take it slower, but be more intense. A general rule regarding tobacco treatment efforts among those with co-occurring disorders is more is better. Tobacco dependence treatment combining intensive cognitive behavioral therapy and multiple pharmacotherapies has shown to be the greatest efficacy in providing care. So we want to have elevated doses or combination of NRT, longer duration of both the behavioral interventions as well as the medication, and also involve the whole care team. There shouldn't be an isolated intervention. Talk to case managers, primary therapists, psychiatrists, let everybody know the goals and objectives around tobacco use. But we find that, again, the more comprehensive and the more intensive intervention is what this population truly needs. Now, smokers with HIV lose more years of life to cigarettes than the disease itself. Tobacco use prevalence among those with HIV is said to we believe it to be about 60 to 70%, which again, 3 times higher than the general population. Now, current antiretroviral therapy is highly effective. The disease can be well managed with appropriate treatment, providing that one is not stressing out their immune system with cigarette smoking and other forms of substance abuse. So there's a lot of overlapping conditions, again, with folks who have HIV. Many will live in poverty, which, again, brings about a lot of stressors. The gay and bisexual men, there's often a fear of being exposed to homophobia, gay bashing, violence. We find a very high incidence of alcoholism in this population. There's a high incidence of mental illness and trauma. Sexual, physical, and emotional abuse is fairly common within this group. So there's added risks for smokers with HIV. The compromised immune system can lead to a risk for additional medical conditions and infection. Studies have shown that persons living with HIV/AIDS who have tobacco use disorder tend to be non-compliant to their HIV treatment plan. So the smokers definitely have a different degree of compliance to their treatment than the non-smokers. Now, this is a large nationwide study in Denmark that was a real eye-opener from a few years ago. Denmark provides HIV treatment free of charge, and they have a much better compliance to treatment just due to the delivery of health care within their country. So this was a nationwide study that was done which identified that, again, smokers have poor treatment outcomes and excessive mortality, that cigarette smoking was a greater cause of death to their patients than the HIV/AIDS itself. Now, the good news is that many living with HIV, and it's believed over 60%, want to stop their tobacco use. Surveys conducted by the New York State AIDS Institute showed that 74% are currently interested in quitting. 64% actually in the survey indicated that they stopped smoking for 1 day within the last 12 months. So it's believed that significant and immediate benefits for HIV-positive individuals can be achieved with more effort by healthcare providers and access to the tobacco interventions. This is a poster targeting gay men in LA, in California. And the New York State AIDS Institute also has begun a campaign to put more energy into addressing tobacco. I believe the Department of Health is actually developing a toolkit for providers. So the high prevalence, why address tobacco, this high prevalence within the clinical population results in unacceptable rates of morbidity and mortality. Tobacco adversely impacts medications and recovery from mental illness and substance use disorders. Behavioral health practitioners have the educational and training background. We practice psychosocial counseling methods that best provides for comprehensive and intensive tobacco intervention. So we basically have all the skill sets, we just need to apply them. The benefits for providing tobacco treatment for HIV individuals, again, it's very exciting. They're significant and believed to be immediate. We seem to have this clinical population motivated to address tobacco, but the services are not there to help them at the moment. Overall quality of care is improved when we include tobacco interventions in our practice, and we see improved treatment outcomes. We can reduce social stigma experienced by those with mental illness and addictions, and ultimately save lives. And this, again, you may recall the slide from our last webinar, but I think it's one worth repeating, that providing tobacco interventions does increase treatment outcomes, long-term abstinence from alcohol and other illicit drugs, and we should definitely want to do our part to address folks with co-occurring disorders. Treatment works if you do treatment, as they say. Recommended resources. I may have shared this with you before, but the American Psychiatric Nurses Association has an online manual that can be downloaded free of charge. It's a very well done manual that I like it for the charts that talk about NRT dosing and different guidelines. Jill Williams, Dr. Williams, developed her program, Learning About Healthy Living. Many of you may be familiar with that, but it's, again, a very comprehensive program of wellness that includes addressing tobacco, but is not tobacco specific. And then also the Choices program, which is a peer advocacy type of group. that has been award-winning and has been very helpful in generating more interest in this. And then if you, this is a New York State website. OASIS is the Office of Alcoholism and Substance Abuse Services, but there are links there. If you go into our tobacco independence link, that'll take you into some education and training videos free of charge. So I want to make sure we left time for Q&A, and it looks like it's worked out. So Janelle, do you have any questions or comments that people are sending to you?
All right, thank you, Tony. Just a reminder, if anybody wants to chat a question in, please go ahead and do so. We have a few here, Tony. One person was referring back to your story about Mary, and they were curious what type of NRT you used and the dosing.
Good question, and I wish I could answer that to you honestly, because to be truthful, it happened a while ago. This was probably, time flies, probably 8 or 9 years ago when that happened, and to be honest with you, I don't recall exactly what it was. You know, when we're talking about NRT and dosing, it's a combination. I remember it was a combination therapy. So there was the skin patch and then something more fast-acting. With, I believe with Mary, we actually even used the inhaler. And then typically what we have discovered is a combination of products work best, where you try to see how in a 24-hour period, well, once you teach them how to use the products, you identify some baseline, this is what we think would work for you, based upon how we're identifying your pattern of tobacco use, but then follow up with that 24 hours later. And you know, she was in this day treatment program every day, so it was easy to track. But it was like, how many pieces of the Nicorette gum did you use? How often did you use the inhaler? So we were actually trying to identify the dose level that was meeting her needs and titrate it appropriately to approach it from that point. So are you still experiencing physiological withdrawal, or was there any evidence of toxicity where you know, too much nicotine? That's what basically the strategy and the way we approached it. But to state exactly what the dosing was, I really don't remember.
Okay. All right, thank you. We have another question. Somebody is asking, when do you think the new clinical practice guidelines will come out?
Yeah, I'm not the guy to ask that question, I'm afraid. I don't know. So I really can't, I have no sense of that any more than you do. So okay. We will see. I mean, it's been, what, 10 years or almost 10 years since the last update, so we're due for sure.
Mm-hmm. Okay. Another question then. You spoke early on about the need to differentiate withdrawal from anxiety, a clinical anxiety that has similar symptoms. Do you have any clues or hints for people about how to differentiate?
Well, the approach that I take is really to teach folks about tobacco withdrawal and the expectations of the withdrawal. And then we need to then, you know, I spend a lot of time talking to them about this. Those of us that have worked in this area around tobacco interventions in folks with mental illness, it was very clear that the fear of reoccurring mental illness symptoms was preventing, it was a big barrier, preventing them from letting go of the cigarettes. The expectation, just like Mary with the snake, or, you know, if I don't use this, I'm going to be in trouble with my mental illness kind of belief system is very real. And we know that when you smoke cigarettes, it elevates anxiety. So you're going to have greater amount of anxiety, more frequent anxiety. So the idea would be to approach this in a way of perhaps teaching someone to cut back on their tobacco use for a brief period of time and just have the opportunity to experience that time where you then have a comparison of what severity of anxiety did you have during that time, and then talk about, while you're exploring this and trying to collaborate with the client to get a true sense of what's going on with them with regard to that, teaching them relaxation, breathing, and grounding, and some DBT type techniques of emotion regulation and things of that sort integrated into the discussion, where they're starting to build on the development of skills to manage anxiety, manage withdrawal better. The webinar we did, the webinar 3, where I was talking about tobacco recovery, I believe sharing with you that sometimes we'll talk about craving and by giving it an entity of its own. Bubba is going to show up after lunch, or at a certain time of day, where how long did Bubba hang out there? What did you do to manage it, to calm down, or to distract, or to avoid any thoughts of the anxious feelings that you were experiencing. So it's really case by case in terms of how do you explore this with someone, but it's a combination of giving them some opportunity where they will be free of the anxious feelings of the withdrawal, and then tease it out. Do you think the anxiety that you were feeling was due to your generalized anxiety disorder, or do you think it was because maybe you had a few too many cigarettes while sitting on the bench? And just start challenging that and looking at it from different angles and drawing some conclusions around it. So it really is this is when we talk about the slower, more intense approach, to have an opportunity to examine that from different angles. The light bulbs will turn on as the skill sets, you experience some success with the process. It elevates the motivation and keeps the ball rolling in terms of the path to being tobacco free. So I hope I'm answering your question.
Thanks. Another question. You had the slide where you showed that smokers with a mental illness are just as ready to quit as the general population. Mm-hmm. So should we be surveying or measuring that among the clients in our own sites? And if so, have you ever had that backfire?
By asking them of their motivation, did we have it backfire? Is that the question?
In terms of if a site was going to survey their patients or clients to say, are you interested, what if a majority of them say no?
Well, I think, again, how you survey folks makes a difference. How you ask the questions, the setting in which you ask the question, whether it be a group or individual. I mean, how do you actually facilitate conducting the survey is very important.
So could you address that in terms of your recommended method for conducting a site survey?
I would do it one-on-one, not in a group. I think that you recall the recommendations I made for tobacco awareness groups, where we're not talking about behavioral change, but just kind of why do you smoke? What would be the reason that we're continuing to do it, type of a thing. After you have some sessions where it's sort of expected that we're going to have discussions around tobacco. If tobacco was never anything that was discussed in the program zero, ever, and then all of a sudden you're doing a survey as to your motivation for wanting to stop, you're probably going to have some different points of view than if you sort of set the stage for the survey by giving some people some opportunity to explore more understanding around their tobacco use behavior. So when we go into facilities like this, we'll conduct, in the residential care, for example, community meetings around tobacco awareness, and just got people used to feeling comfortable and talking about this in a more significant way, where they're sort of exploring their own thoughts and internalizing their own thinking around this. Then we would put out the surveys, because is it the fear of, oh my God, they're going to take away my cigarettes, and then you get this defensive kind of an attitude, or is it a really objective, would this be something that would be helpful for me to do kind of thinking? So when the surveys are conducted, after we sort of neutralize the fear and not get into a sort of a group mindset. I was in a program in a hospital-based program here a couple of weeks ago, and the folks asked me to come in to facilitate a tobacco awareness session. And because I was there, the director was, wow, we're really doing this. This is exciting. Let's pack the room with as many patients as we possibly can. So I walked into this place, and it seemed like 100 people in the room. I don't know how many were actually there. But then when we started talking about tobacco, it was like blindsiding the group. They didn't know what the topic was going to be, and all of a sudden I'm talking about this, and then it was, what are you going to take away our cigarettes? And there was sort of this wave of anxiety that went through the whole group, where it really led to a different kind of discussion. Where if I had a smaller group, where I could have done some type of group motivational interviewing and reflective listening and probing and looking at both sides of the ambivalence, that was not going to happen, because the group was too large, and it was just the setting wasn't appropriate to it. So I think to make sure that you are a setting and sort of setting the stage properly before you can start objectively looking at motivation and stage readiness, it's an important thing to do. One-on-one individual sessions with clients is a wonderful time to explore this. If you do it in a one-on-one session, and the decisional balancing exercise, or the question would be, how would your life be better tobacco-free? And just not looking at the change process, the withdrawal process, not the act of doing it, but what would be the difference? The old miracle question: if you didn't smoke tomorrow morning, the miracle happened. Cigarettes were not an issue for you at all. How would your life be different tomorrow than today? And so to identify the benefits, and then the consequences, the difficulty of the change process is where the fear comes from. So to set the stage and to be able to look at that, I think you can get some realistic, more objective responses with regard to stage readiness.
Okay. So we have another comment. How do you approach a patient who states that they smoke instead of doing harder substances?
Yeah, well, that's pretty common, actually. Substitution. I mean, you find that with a lot of other substances as well, not just tobacco. We used to talk about the marijuana maintenance program for folks that are, using heroin and other substances, where if I'm not using that harder substance, as you say, I'm doing something else, it's better for me. And there's arguments for that, but I don't think you're changing the behavior. The defense mechanisms of self-medicating with a substance is still there. We've talked about all the parallel patterns of behavior with regard to the use of different substances. The justification for how or why I would want to pick up my next drink if I have an alcohol use disorder are probably the exact thinking and justification of why it's okay to light up my next cigarette. So the cognitive and behavioral processes of change, which is really what drug rehabilitation is about, is adversely affected if we maintain the focus and that belief system in one substance, even though it may not be considered your drug of choice. So the way I respond to that when these discussions come up in group counseling and such is, I hope you realize that at some point in time there are healthy alternatives to that substance. You don't have to choose another unhealthy replacement. So, what would be a healthy way to manage anger? What would be a healthy way to cope with anxiety? Instead of grabbing a blunt or a cigarette or a drink or fill in the blank, can we sort of expand our menu of options and start looking at other things as well? So it's, again, rolling with the belief system, not judging it, but letting people know that there may be alternatives beyond the immediate way that they're thinking about it.
Okay, one person says, did I understand right that smoking and the taking of medication, especially those used in mental illness, makes the medications less effective?
Yeah, and again, that's those polycyclic hydrocarbons affect drug metabolism. I'm not a psychiatrist, so I'm not a specialist in this area. You'd have to speak to someone who is more training in that. But from my understanding of it, that is the case, where we then will find typically higher dosing of medication among the smokers versus the non-smokers. And again, that can lead to more side effects from the meds and more discomfort among the patient. So when you're stopping smoking, the reason, if you remember when I talked about Mary, where I said that I collaborated and consulted with her prescriber, it was a psychiatrist in the unit there. I wanted to do that because I knew that by stopping her tobacco use or by reducing her use of tobacco, there may be an impact to the way that her medications were working as well. So there needed to be good communication taking place there with some of the changes that she was making with regard to this.
All right, does anybody else have any other questions? Please chat them in. And Tony, as a follow-up to the question about the medication, can you add a word about caffeine as well and how that needs to be adjusted as people come off of cigarettes?
Great question, because we don't isolate this by just looking at the cigarette. So when somebody asks me for help to address their tobacco use early on, when we first are starting to get to know one another, I will explore with them overall diet. So what kind of eating behavior, how, is there sugar consumption that's in excess, or is there, different types of need to make changes in that area, and caffeine is a big one. And so we talked about how the metabolism can change with regard to medications due to the use of tobacco smoke. Well, it also impacts sugar metabolism and how the body reacts to caffeine. So if you do stop, nicotine's a stimulant; it revs things up. So if you're drinking a lot of coffee or caffeinated beverages, and you stop your tobacco use, the way that your body metabolizes the caffeine is going to be different. It'll promote more anxiety, more anxiousness. It's metabolized differently. So many people who will try to stop their tobacco use but not change their pattern to the coffee or caffeinated beverages will complain that I stopped smoking cigarettes and I'm very anxious, or I can't sleep at night, or some of the symptoms that they are speaking to, where it may be more of a reaction to how they now are being impacted by their caffeine use, and it's not really even cigarette withdrawal, that even though they think it is, that is the challenge here. So right from the get-go, if I see someone who is using a lot of caffeinated beverages or is eating a lot of sugar products, we'll talk about making some changes to diet and the caffeine prior to even either slowing down or stopping the tobacco use. I think it's very important. You don't want to set someone up for failure, and if these are true barriers with regard to caffeine or sugar, we want to make sure that that we talk about that, give some instruction. And it actually can be a very useful thing too, because many times people will be anxious or have some sense of hopelessness around letting go of the cigarette. But if before we even get to changing the behavior around the tobacco use, if we can help them slow down on their caffeine drinking, and they're successful at that, it encourages them to say, wow, I really did that, and it can then promote further changes, which then lead to the cigarettes as well. So it all kind of relates to one another in terms of how we can be encouraging and hopeful and demonstrating some success with behavioral change. But yes, we definitely, if someone's a heavy caffeine user, Janelle, I never would try to develop some tobacco intervention until we address the caffeine first.
Great. Any other questions that people have? Or if not, Tony, is there anything that you wanted to elaborate on that you wish you could have had more time for?
Well, again, the idea is that jump in the water, it's fine is the key here. The way you learn this stuff is really doing it. And again, in our programming, we know behavioral change. I mean, folks that work in addiction services and in psychiatric care, I mean, we're the folks that are in healthcare that seem to know more about behavioral change than anyone else. So to just apply what we know, and we don't have to be perfect, but as long as we have that connection of being honest and genuine and working with our clients to make positive changes in their lives, good things will happen. And so if there's hesitation in addressing tobacco because I don't know the proper dosing of NRT, or I don't want to make a mistake, or I'm not sure how to answer the questions that I'm going to be asked, I would encourage you not to let that discourage you from just starting the process along. This could be very simple interviewing skills of why do you smoke? And then, look at, as you ask those questions, you're going to naturally find the path to carry the conversation forward that can help somebody explore what they're saying, and it can, then lead to different techniques can be very helpful. So I hope, the series that we're doing, we have one more webinar after this on vaping and electronic cigarettes. I believe I wanted to share some information there. But the series overall, I hope the folks that are participating today have found it to be somewhat helpful in just engaging folks in the conversation, learning about everything I know about this. I learned from my clients. All right. Now, yes, I read the research and I talk to the experts and I do all that as well, but to apply the research to practice, you really have to live it and spend some time with focus groups and doing surveys and in that one-on-one conversation of what is this about, to identify the fears and the barriers and how we're going to address that. But what you're going to find is that this is not so different from a lot of other interventions that we do every day of the week. How do you encourage someone to stop smoking weed, or how do you, encourage someone to make some other type of behavioral change in their life? It's not all that different than talking about cigarettes once you feel comfortable with it. So the techniques, the counseling methods, the intervention skills, the support, the empathy, all of those elements of good therapy and counseling are things that I think we all have in common if you work in this field. And so, again, jump on in the water is fine. If you just start engaging and beginning the process along, you're going to find that you're going to be more confident and more skilled in how you can help folks with this, and we really can help folks with this. I mean, it really does work. I believe that it is disrespectful to think that someone who has psychiatric illness or some type of substance use disorder doesn't deserve good health or being tobacco-free. I think that everyone is capable of it, and we need to do whatever we can to assist with the process. And again, it is effective if we continue to pursue it and understand the nature of substance use disorder and ways that we can make a difference. So again, I would invite anybody to, you could send in questions or comments, or if there's any other assistance that I can offer, I'd be more than happy to entertain your comments, questions, or any feedback that you would have for me of how I could be of more help to you.